I'm trying to share it. Okay, can you see it?
Yes, we can.
Okay. Sorry. Okay, here we are. I would like to start my presentation with a number. My number is 1 billion, and according to a very recent study published last February on Lancet, this is the number of this is the total number of children, adolescents, and adults living with obesity. Some key points that we already discussed, but just metabolic and bariatric surgery is the treatment of choice for children and adolescents of class 2 obesity or class 3 obesity or class 2 obesities with associated comorbidities. An early referral to a multidisciplinary program when a child reaches class 2 obesity is critical to best outcomes. And it has been documented, unfortunately, that lifestyle change, diet, exercise, or obesity medication are not more considered adequate treatment for this condition of severe obesity. And there are still bias and some kind of prejudice surrounding this subject that play a role in the delay or the inadequate use of bariatric surgery in treatment of severe pediatric obesity. That's why in our hospital in 2012, war has been declared on obesity. And just in 2012, a plan was developed to create the first pediatric center for obesity treatment with the creation of a multidisciplinary team, with the first surgical procedure performed at the end of the year in a patient affected by Prader-Willi syndrome, with start of our training with sleeve gastrectomy in May 2013, and with the start of training with the gastric band in June 2018, and with the first our operative session with the 4 sleeve gastrectomy performed in the same day. Of course, indication for bariatric and metabolic surgery is given after failure of diet, lifestyle change, possibly intragastric device. And according to the most recent guidelines, evaluation of pubertal and skeletal maturation, such as autism, development delay, syndromic obesity, mental illness, or prior trauma, are no more contraindication to a surgical treatment. Of course, underlying pathologies has to be considered when we offer surgical treatment, such as age, underlying medical condition, previous treatments, and their effectiveness, and BMI trends. BMI, we all know, is the factor that evaluate in case of a surgical indication. And according to the most recent guidelines, as also has been approved by our Pediatric Surgery Association, we have to consider indication to surgery in case of BMI more than 35 or 120% of the 95th percentile with clinically significant associated comorbidity, or BMI more than 40 or the 95th percent of percentile. Of course, a multidisciplinary team must also consider whether the patient and family have the ability and motivation to adhere to the recommendations that we give before and after surgery, including consistent use of micronutrient supplements. In case of BMI between 30 and 35, we propose the intragastric balloon treatment. With the BMI between 35 and 40, we used to propose the gastric band, even if, as we know, the gastric band is now no more accepted. And to date, this procedure has been restricted to individuals 18 years and older by the US Food and Drug Administration. And in case of BMI more than 40, we propose laparoscopic sleeve gastrectomy. Just a look to what is probably the short-term future in case of a BMI between 35 and 40. There are these new tools that are now becoming available. Of course, we have to have more data and to have more patients to evaluate their results. We are at the moment waiting to get the authorization to use the body clip that seems the most attractive. The body clip, just two words, is consists of a silicone-covered titanium backbone with an inferior flexible opening that separates the median lumen of the stomach from the excluded lateral gastric pouch. We can say that it marries the best quality of the sleeve gastrectomy with removability. It is always a restrictive procedure. The bottom opening is the bottom is open, so to let the lateral segment amp. We can say that is a clipping and is not a cutting procedure, is always a restrictive procedure, and the entire stomach is accessible by endoscopy. But of course, we will see. We have still no experience on this. When we talk about the surgical option for treatment of surgery, of course, we have always to think that we are dealing with the adolescents most of the case. Adolescence is often an unreliable patient. They suffer because they see their body image modification, but we have always to get their consent and their agreement. So when who decide on surgery, when to operate, what type of treatment, when to operate, and when decide to go to surgery, we have many tools. We are assisted by our psychologist or psychiatric in case of use of medication to assess the characteristics of the patients who undergoing bariatric surgery. Let's talk about our experience on laparoscopic sleeve gastrectomy. As you can see, is essential to prepare the patient in the operating room, and we use a French anti-tremblement position and with the legs spread apart. And in the photo on the right, you can see the placement. We use 5 trocars, one trocar in the of 12 millimeter in the left paraumbilical region, one in the right umbilical region, one in the epigastrium, one 5 millimeter trocar in the epigastrium, and 2 millimeter trocars in the subcostal left area. We start with the, probably we'll see later on, the dissection of the gastrocolic and the gastrosplenic ligament with the ligature starting 5 or 6 centimeters upstream of the pylorus and continuing until a complete release of the esophagogastric junction is achieved. We then perform the gastric sleeve calibrated on a 40 French calibration tube using 60 millimeter sequential firing. We use a electric stapler, Signia electric stapler with polyglycolic acid reinforced reloads. We don't leave a nasogastric tube after the procedure unless invasive ventilation is required. We do not perform any more methylene blue test, and we put a peritoneal drainage only if some bleeding occurs. In order to reduce the risk, we use an optical trocar to first access, avoiding a blind access with the VELS needle. And the VELS 1 fascial closure system is a multifunctional tool that serves as a trocar and as a fascial closure device at the end of the procedures. Then we have operative trocar blanket tip and reinforced endogia reloads. To reduce stress and pain, we perform an endoperitoneal pain therapy at the beginning, at the end of the procedure, or our anesthesiologist perform a tap block, a transversus abdominis plane block at the beginning of the procedure. And we remove the nasogastric tube unless NIV is required. We can say that we introduce a fast-track program after bariatric surgery for our patient, with the early mobilization in and clear fluid diet allowed in the first postoperative day. In second postoperative day, semi-liquid diet and, if present, removal of abdominal drainage, and in third or fourth postoperative day, discharge at home. This is one of our happy patients. Postoperative follow-up consists of a follow-up clinical examination at 10-15 days after the procedure. At 1 month, we perform a digestive X-ray and allow the patient to get free diet. And then we perform 3, 6, 9 months outpatient clinical evaluation with evaluation also from a psychologist if necessary. At 1 year and 5 years postoperative, we perform esophagogastroduodenoscopy with the assessment of comorbidities. Of course, based on clinical needs, a customized clinical assessment is performed. This is the normal anatomy at the postoperative digestive X-ray performed 1 month after the procedure, showing the thin tubular pouch with the freely passage of contrast media through the sleeve to the gastric anchory. And this is our experience, surgical experience. We performed a total of 289 procedures. 267 of them were sleeve gastrectomy, 21 gastric band, and 1 diversion at the beginning of our experience. Associated pathologies in 21 patients, as already has been shown to you. And these are, we analyzed our first 183 patients. 61% of them were females. median age is 16 years old. Our youngest patient that was operated on was 13 years and 7 months. Mean intraoperative time about 1 hour and a half. About 60% of our patients were admitted at the ICU in the postoperative time, and they stayed in the ICU in median 1 day. The total length of hospitalization was about 4 days. The mean preoperative BMI was 45.38. We have results available for 161 patients. And we had a median BMI reduction of 15.63 at 1 year follow-up. That is almost stable at late follow-up, about 4 years of follow-up at late follow-up. And at 1 year, we had 34% total body weight loss, and almost stable at late follow-up, and 63% of excess weight loss. This, if we analyze the non-syndromic patients, and in which you can see that the effectiveness in terms of weight loss is valid also in such series, considering both the reduction of BMI and the total percentage of weight loss, as well as the percentage of excess weight lost at 1 year at late follow-up. Also, in terms of associated comorbidities in this patient, we had a significant improvement of all the comorbidities that was achieved due to the excess weight loss. And if we look specifically at the NASH, non-alcoholic steatohepatitis, and hepatic fibrosis, we performed a study on our patients, and our patients were divided in 3 groups. One group who underwent laparoscopic procedures, bariatric procedures, and one group that underwent non-surgical weight loss, and the third group where lifestyle intervention were associated to intragastric weight loss device. And as you can see, the group who underwent laparoscopic sleeve gastrectomy was followed by a significant improvement or even reversal of hypertension, POSAS, dyslipidemia, impaired glucose metabolism, and POSAS. And if we look specifically at the fibrosis, at the hepatic fibrosis, at the assessment of liver damage through a hepatic biopsy performed on 51 patients after 12-18 months after the procedures, you can see that the hepatic fibrosis improved significantly after surgery. Complications. We had 3 gastric fistula complications. That is more or less the reported incidence in the literature. We had a pleural perisplenic hematoma that underwent to spontaneous resolution, and 1 pelvic abscess in a patient where a laparoscopic drainage was necessary. As late complication, 3 cases of anemia due to nutritional deficiency, and 2 Wernicke's encephalopathy due to deficiency of B1 vitamin. having a look to the gastric fistula. In the first patient, this complication occurred in the third postoperative day due to a technical error, and a redo laparoscopic surgery was performed with mechanical suturing. The second patient had a huge gastric fistula with big stricture. We use in that the day of the surgery a bougie of 36 French. So the patient underwent to proximal gastrectomy with the esophagojejunostomy in another institution. And the last patient had a late recurrent gastric fistula and underwent to endoscopic conservative treatment by a pigtail that was left in situ for 3 months, and then the closure of the fistula with the endoscopic approach. These are the incidence of gastroesophageal reflux disease. You can see here in the short-term follow-up, we have now 9 patients. So short-term follow-up means the first esophageal gastroduodenoscopy performed after 1 year. So about 8% of patients. And in the late longer-term follow-up, 5 patients. No patients have a Barrett esophagus, so at the moment they are on a surveillance program and on PPI therapy. Postoperative plastic surgery must be considered in case of a significant cosmetic issue, and it can be considered only at least after 2 years after the procedure, when the patient has a stable BMI. And this, you can see the kind of surgery that was performed by the plastic surgeon. These are two brothers, our patients that underwent surgical procedure. They used to have dinner at McDonald's paying more than 50 euros, and now they can manage with 10 euros. And thank you for your attention.
Thank you very much.
Thank you, really, Emanuela. Mario, may I?
Yes. Please.
May I do some questions? First of all, Emanuela, you did really an excellent lecture, but we know you very well, and we know also your competence and how much you are devoted to pediatric surgery. But I want to discuss with you, and if Olga is still with us, the complications that you presented, I suppose that were all complications of sleeve gastrectomy.
Yes.
And the question is, do you perform just a stapler resection, or do you add to the stapler resection a continuous handmade suture? Because I remember that at the beginning of experience with the sleeve, especially Olga underlined the importance to do a second layer handmade. And I have to say that also our general surgeon in Milan, I did a few cases with them, they used to do the same technical approach. What is your opinion in this?
No, we use only mechanical stapler. We have the reinforced stapler. We use polyglycolic acid reinforced stapler. So we do we performed only the mechanical. I guess maybe in the treatment of the first case, probably we at the beginning we try to, because I was in the OR that day, probably we tried to put a reinforced, but it was difficult to be sure not to cause to strict than a stricture. So we perform just the mechanical. I mean, in the elective surgery, we perform my answer is that we perform always only a mechanical stapler using reinforced coated. But in the emergency, I have experience with this first case, and if I can remember, we tried to put a second layer, but it was it was
it was challenging.
Yes, it was challenging, and to be sure not to cause a stricture.
Olga, what is your opinion? You are the expert.
No, I'm not the expert. I just know that Emanuela is dealing with very difficult patients, and complication management, I think, is the king discipline of anything. Anybody can operate well, but treating the complications in bariatric patients is the most demanding thing. Now, well done, and again, success proves you're right. Well done, super job, very professional.
Thank you.
I am amazing what you are talking about, you know. That's completely strange field for me. We have no experience with bariatric surgery until now. Just only a few centers are in Poland, and I have seen that you collected such a great number of patients. Unbelievable. So probably the epidemic is coming to Poland, and we will shortly start with this. But until now, you know, we are thinking about it, but still not have enough patients. And sometimes I just send patients to adult surgeons because when they are 16, 17 years, it's no challenge to start for such a patient in pediatric surgery unit, I think.
Thank you.
I think they are all adolescents. The problem is that this, in my opinion, has to become also a field of interest of pediatric surgery or adolescent pediatric surgery in a team with adult bariatric surgeon too, in order to be to offer the best technical quality that we can offer.
I have a question for Emanuela, for Holger. Emanuela, what do you think is the number of the patients that we have in Italy? Because it's important to organize the very important center to treat this pathology. I see that you have a very big experience because 185 patients, 2008 today. And what is the number that you think we have in Italy of child and adolescent that need this surgery? Because this is very important to know if it's possible to organize one centrum in the north, in the centrum, and in South Italy. What is the number that you think? Really is not scientific question, but
the prevalence of the disease.
I mean, no, and the problem is that it's improving. I mean, it's becoming bigger and bigger. I start my, the experience when we started with Dr. De Peppo, my chief. We started with about 20 procedures per year, but now we have a waiting list of at least 50 procedures. So is becoming bigger and bigger. I think that the accreditation criteria for because we all know this kind of surgery can be performed from adult surgeons, but since it's becoming, we have seen 1 billion of people, it's becoming a very huge problem. I think that probably a center with specifically dedicated to this problem in the north, in the center, and in the south of Italy should be the right answer to a question that is becoming bigger and bigger. So I still don't know, but now I can say that we have almost our waiting list of sleeve gastrectomy is at the moment about 40-50 procedures.
Thank you very much. And if you want to organize in Italy, I think that 3 centers is good. What do you think?
Maybe yes. I mean, I cannot answer, but maybe yes. Then there is also, you all know that there is the Italian Society of the SIGOP, the Italian Society of Bariatric Surgery, that gives criteria to get accreditation for the center, and you must respect I mean a number of procedure. You have to have a number of patients in waiting list. You have to perform some revisional procedures as well, so there are some criteria. But I mean, I think that a part of the pediatric surgery world, I mean, pediatric surgery, national pediatric surgery can be dedicated to this topic, since it's becoming. And what is important also what we discussed earlier, if I think that there is some prejudice still, and before it was difficult to have, for example, an indication for a neuropsychiatric, but now is the contrary, is the neuropsychiatric that is asking us to operate on. So the indications are becoming also wider. That's why the numbers are becoming bigger. So probably yes, even if I'm not the right person to answer to your question, but I think this should be the right distribution.
Yes, my question, the reason of my question is for this, because I think that is very important that the adolescent was treated from the pediatric surgery. Because if you are not organized in Italy, many adolescents go in the adult center, and I think this is not correct. Not correct for the number of pediatric surgery, is not correct for the psychological problem.
Yes.
Because the psychological problem of the adolescent is very different of the psychological problem of the adult that have this problem, this pathology.
Mario, if I can say something, I totally agree with you. And this is the reason because I proposed the bariatric surgery as a subject for our group. But I have a look just on the internet, nothing more. And in Italy, the Society of the Pediatric Society and Endocrinology Society consider the prevalence of real obesity, not overweight. Real obesity 10% in the till 19 years of age. So is a high prevalence. It's not so small.
Olga, if you is connected, what is your opinion? Olga? Okay. Okay. Now there is also
Olga is here.
Okay. Yes.
Olga just has to go to the bathroom.
Now, what is your opinion about our discussion of the number of centers that we need in Italy for this surgery, pediatric surgery, and what is your opinion about the adolescents? Because for me it's important, and also for Giovanna, that the adolescents is treated in pediatric center and not in adult center, because the psychological approach is very different. What is your opinion about this?
I mentioned it a couple of times when giving feedback this morning. I think that bariatric surgery, metabolic surgery must be centralized. And within these centers, there should be at least 4 disciplines treating the whole spectrum of patients. That is a surgeon and a pediatric surgeon, that is an adult and a pediatric endocrinologist, gastroenterologist. These 4 together. What's the benefit? The benefit is, for example, when we team up with adult surgeons in bariatric procedures, instead of making 5 to 10 by ourselves, we see 100 per year. So excellence, expertise, complication management, suturing, anastomosis, which stapler, where and why. It's an easy business then if we operate together with adult surgeons. They have the numbers, we have the skills for the pediatric adolescents patients. Second, transition. Usually the guidelines say that these patients, that our patients should be operated by the age of 16, 17. So they are already close to being adults. If we do tackle them because of the severity of the comorbidities at the age of 16, we need somebody to transition them when they're 18 or 19. Again, the team makes sense. I believe, like the Americans do too, this is a very delicate special surgical specialty. Metabolic surgery must be centralized in countries. And each center must prove that they offer the whole spectrum of treatment to these patients, especially the conservative treatment, preoperative, intraoperative, and postoperatively, and a very experienced interdisciplinary surgical team. I think in Germany, there are only 2 or 3 at the most. Most adolescents are being treated by an adult surgeon, not good. But pediatric surgery doesn't really pick it up. Here in Austria, we have an adult surgeon in Zell am See who is doing an excellent job. And for example, in Styria, myself, I don't see patients. People just are too good at biking, skiing, running, whatever they do in sports. And in Italy, you know better than I do that there are very good teams and they should have the support. These patients can travel.
Thank you very much. And if the scale is 100 per year, I understand well that you say, Holger, for a good scale. Emanuela, I think that one center in Italy is sufficient because 100 cases per year is good or not? This is a problem because
yes, the problem is that if you look at the accredited adult center are at least 20. So
I exaggerated a bit. 20 is fine.
I feel sorry for our for our specialty, but
no, I'm fine with 20 together. Sorry.
Let's do 2. Let's do 2 in Italy, okay?
No, yes, because ISIS 20, I think that need 3 center in Italy. But if it is not 20 is good. And Holger, you think that 20 cases per year is a good scales for the problem, the complication to treat all?
Well, I think, I think 20 comes from the Americans, Emanuela, correct?
Yes.
Yeah. So that is the minimum that they should do.
Yes.
But again, this answers your question very nicely, Mario. There will never be a center in pediatric surgery that does 20 cases per year of adolescents, never, alone. So we need to team up with adult surgeons if we want to make those standards. And I think 20 is the minimum to be done. If you have 3 surgeons and 2 techniques, the bypass and the sleeve, you dilute the experience quickly. So I think no matter 20 upwards, but team with adult surgeon. And you don't lose. You're still the pediatric surgeon that is responsible for the case. Easy.
Yes, but I think we have to integrate the team, as Mario underlined before. So it's the more simple things is to be connected with a big adult center. And if you look to the picture of the center in Bologna, there are a lot of specialists inside, nutritionists, psychologists, anesthesiologists for obese and many other gastroenterologists, a lot of competence. I have read more than 10 different specialists. So
Bologna is perfect.
Yes,
Bologna
but
is perfect.
we need to join the pediatric part. We need to join pediatric endocrinologists, pediatric psychologists, pediatric nutritionists, and so on. So we need, in my opinion, if someone want to establish a center, the numbers are important, but it's very important to establish a pediatric team connected to the adult one, because I think we will have not enough surgical experience for all, for find all the best solution for all possible complication. So we need to work with the adult specialist, but we need to offer a pediatric team.
By the
Absolutely.
way, we perform 20 procedures per year. During the COVID era, we were allowed to perform this operation as an elective procedure, the only procedure that we are allowed to perform. We arrived to 43 in 2020. So we get, I mean, we get patients from most of center and all the south of Italy. And we are about a little bit more than 20 operations per year.
Okay. Thank you very much. It's very interesting discussion. Holger is satisfied.
I said it, Mario. You're doing such a great job, and it's a perfect setting that you have. Perfect.
Yes, but this is another advantage of our group, that we have time for the discussion.
Super.
When need, or don't discussion where don't need. And now I call the second question time, if Gentilino is ready. And after the question time, the second question time, we have the break for the lunch. And I know to the operative theater about what is the time to the start, and we conclude with the second surgical procedure, laparoscopic surgical procedure, is the slave gastrectomy. Valerio, if you want to start.
Yes, Prof. Again, my role is very minimal as usual. I'm just giving the floor to Carlo Ferlini. He's a pediatric surgical resident from University of Brescia, currently working in Pavia, and he's going to present the second question time about another confusing and weird clinical case. Please, Carlo, share your screen.
Good morning, everybody. It's a pleasure to be with you today. I'm going to share my screen. All right. So can you all see it and hear me?
Yes, we can. Carry on.
Thank you. Okay, so today's case is one I found in the literature, a quite unique one, as you will see. And it's about having the stomach for facing the unforeseen. In fact, it's about a very rare complication of sleeve gastrectomy. So our patient is an 11-year-old male who underwent sleeve gastrectomy due to very morbid obese. He had a body mass index, as you can see, of 55 kilograms per square meter. And his postoperative course was initially uneventful. He even did a subsequent barium meal, which showed no anomalies, but 5 months after the operation, he presented to a peripheral hospital with a fever, followed by productive cough and dyspnea. So it's a no-brainer. It was first underwent a chest X-rays, which showed a left lower capacity, and he was admitted to the hospital and treated for community-acquired pneumonia. However, despite an intensive antibiotic course, he failed to improve. So, here's the first question. Given the anamnesis and his clinical presentation, which second-level diagnostic test would you have performed? Perhaps a lung ultrasound, a TC or MRI scan? Would you have performed an endoscopy or other suggestions that you might have? Now we see what the doctors in our case chose for this patient. Because, you know, it might seem a case for the pediatrician first, but we'll get there. It's not exactly a straightforward answer. Okay, so I see that the majority of you has chosen the CT MRI scan. So let's see what were the results. Exactly, so it was referred to the primary surgeon who decided to carry out a chest computer tomography with oral contrast. And the procedure showed a leak of contrast into the peroral space. So a diagnosis was made of a gastroperic fistula, which is a rare pathological communication between the stomach and the pleura, which may develop secondary to infection, malignancy, and surgery, and has been described, especially in the adult population, after a sleeve gastrectomy, as our patient underwent. So, now that we have a diagnosis, how could we help him first? Should we choose maybe to change antibiotics, have an alternative to oral nutrition, for example, by putting a feeding tube or parenteral nutrition with peroral drainage, or should we resort to a minimally invasive approach through endoscopy and try to close the fistula, or go straight to surgery, for example, with a laparoscopy or a partial gastric section, Roux-en-Y esophagogenostomy? So let's see how you think. I want to precise these are oral alternatives, which I found have been described in the adult literature with varying degrees of success. So there are more than one possible answer here. It's just a matter of which to apply first, mainly. Oh, that's interesting. I see it's quite equally split between a conservative treatment and endoscopic closure, with some of you would rather go directly to laparoscopy. Anyway, I seem to find that the majority of people would like to start getting things done who are less invasive. Let's see what they chose. Laparoscopic surgery for fistula closure. So they decided to start a little bit strongly, as you can see. But intraoperatively, there was a surprise because a left lower lobe abscess was found, measuring around 5 per 6 centimeters. I don't know whether this was described in the first TC scan. This was not explicited in the original clinical case, and I do not know the time which went between the first imaging and the operation. Again, this was not specified. However, since this complication was found, a decision was made to convert the procedure to thoracotomy for fistula closure with left lower lobectomy. But you guessed it, it's not over yet, because an unspecified lapse of time after the intervention, the patient started presenting with persistent chronic cough and fluctuating fever. He underwent another barium mail in follow-up and still had a leak at the side of the fistula. So frustratingly, no success. Moreover, he did repeat a CT scan, and he had this time another complication, multiple and cystic pockets of fluid within the pleura. So the situation has gone from bad to worse. So what do we do now? We must resort to another treatment. Should we go for an even deeper operation like partial gastric resection, Roux-en-Y esophagogenostomy, address first the thoracic problem with decortication and drainage perhaps, or resort to other options that you may think of? All this, I must say, was conducted not in the hospital. It was initially operated from what I understood in the case, but in another peripheral hospital in communication with the surgeon who performed the initial operation. And the country is Saudi Arabia, just for your knowledge. So it's quite evenly split, almost equally split, between all the options I proposed you. That's interesting. So it shows that there are really no consensus at this point about what we should do, and let's see what our colleagues decided to do. The thoracic complication was addressed first and treated with video-assisted thoracoscopic surgery for decortication. This time they decided to put a gastrovaginal tube for feeding, and the second tube was introduced through the fistula opening for drainage. At this point, the decision was made to take the patient and transfer it to the tertiary center where it was initially operated. So let's start over. He underwent another assessment upon admission. He had a fever and a chronic dry cough, which were still ongoing. Therapy with empirical broad-spectrum antibiotics, clindamycin and ceftazidime, was put in place, and was put on a neoperos regimen with strict gastrovaginal tube feeding. 4 months after the second operation, the patient underwent an endoscopy, which showed a 5 mm fistula opening just below the gastroesophageal junction toward the posterior wall of the gastric fundus, and another chest X-ray and TC scan around this time showed again contrast leak and loculated encystic fluid. Judging from what was described in the case, we had no clear indications on how well did the patient fare during this long lapse of time. For example, we don't know exactly how much fever, how much cough, how this did impact on his life, but we may fairly assume it was at least manageable. So we arrived at the point at which it is necessary to resolve the situation once and for all. So I would like to hear from you what would be your final choice for solve this case once and for all. Should we do redo laparoscopy with fistula closure? Again, resort to major interventions such as partial gastric dissection, Roux-en-Y esophagogenostomy, or maybe try another less invasive road with endoscopy and try clipping and plugging the fistula. Let's see how you think about this. Again, these are all feasible options which have been described in the adult literature, but for the pediatric one, we don't have clear indications, also because there are only, as of 2022, only 5 cases described in the pediatric literature. So you see, it's very difficult to apply an algorithm to such a rare complication as it is. And this is perhaps the only case of a fistula after a sleeve gastrectomy. Okay, so the answers, once again, are very, very evenly split between all the options I gave you. As for before, so let's see what was the final decision. Endoscopy. So an over-the-scope clipping was applied to close the fistula using endoscopic suction. The patient had no post-procedure complication and was discharged on gastrovaginal feeding and follow-up to ensure no leak was persistently found. So how it ended? 4 weeks after the endoscopy, a barium meal this time showed finally no pleural leak. He underwent a follow-up chest X-rays and CT scan, which showed a marked improvement in the aeration of the left lung, no pleural leak, and the regression of the pockets of encystic fluids. Antibiotic therapy, of course, was still ongoing. And at last control, 10 months after the endoscopy, his BMI was in a range of normality, oral feeding was gradually and fully resumed, and he had no apparent sequelae. So that's how it ended fairly well, with this unusual decision of applying a less invasive method after major operations had been done, but with perhaps an unexpected result, which solved our problem. As I told you, it's quite unique because it's the only case in the pediatric literature of a gastropleurotic fistula after a sleeve gastrectomy that I could find. So I have finished. I thank you for your attention, and I'm open to your answers and curiosities if you have one.
Thank you, Carlo. I want to congratulate with you and Edoardo, because today you've done such a great presentations, actually. So the presentation is open for discussion. I believe this case is quite a weird and confusing case, as we said before. So it's difficult to make any comment or any questions, but of course, our discussant got probably comments or questions.
I have a comment. I think I don't agree with the first approach to this complication, because if I use the laparoscopy, when I isolated the gastric fistula, the gas go in the thorax. And for this reason, we have whole complication. But I think that the better way is to open immediately the patients, because it's possible to close well the fistula, and it's possible to check well what happened, because it's open also the diaphragm if there is a fistula, gastric pleural fistula. This is my opinion. And probably the history of the child is very different. I don't know what you agree or what you think about this.
Thank you.
Mario, I have to say
Sorry.
that I have the same reflection. I want to open this patient and not to approach laparoscopic.
Yes, in the first time, I think is important to open, because with the gas of pneumoperitoneum, there is a diffusion in the pleura. And
the other option could be to start immediately with endoscopic suction.
yes,
That could be the first option at the end, because we have seen that it worked. But I have experience also with endoscopic esophageal suction, and it was not so successful. So it is not always successful, but you can try. And if it doesn't work, you have to open, in my opinion.
but because if you see the X-ray of the second, why there is an abscess in the upper part of the lung is because with the gas go. I think probably.
Can I make a comment?
Yes,
Please?
Mata, yes.
Okay, thank you. Thank you so much. One of the three cases of complication that my colleague Ceriati shows just before, one was very similar to that one. It was not a gastropleural fistula, but it was a high gastric fistula with no gastric fundus renant. So it was the second time we had this complication, this type of complication. And the first one, we had a fundus renant, so with a stapler, we resolved laparoscopy and stapler, we resolved the problem. But in this second case, we tried to do the same thing laparoscopically, but no fundus, no place to put some stitches over. And I think that is our mental predisposition to operate patient where there's a complication, because you are a pediatric surgeon. But adult surgeon, I think, have a much more experience with endoscopy, and they are more skilled in this. So we contact our colleague of bariatric surgery in the adult, and they suggested us to do nothing more operatively, but to drain both the fistula and the gastric remnant with a nasojejunal tube for feeding, and putting transfistula tube that we retracted daily to make fistula close and to drain the abscess near gastric remnant. And after quite 2 months, fistula closed and the patient get well.
3 months. There were 3 months.
3 months. Okay, thank you, Manuela. I didn't remember exactly because it's your case, but I think it's important collaboration. with adult bariatric surgeons, and to start with the less invasive procedure, and then to move to more invasive one if the conservative doesn't function. Thank you.
Thank you
Thank
very
you very
much.
much. Carlo, what's your take-home message after having gone through this clinical case?
Yeah, I think that in such rare cases, we should perhaps look for clues in the adult literature. So I quite agree with what was said. Perhaps I think that a more conservative approach, at least in the beginning, would have been preferred.
Non ti sento, Mary, ti sento malissimo.
Yeah. Sorry?
No, carry on, Carlo.
Okay. So, because we had, as it was said, an inflammatory situation in the thorax, so in my opinion, it was important to first try and solve this, at least to let the situation become less inflamed and infecting the other district, and then look for some form of repair which was, at least in the beginning, less invasive, and if that did not work out, maybe go on to more open surgery or laparoscopic surgery. In general, I would conclude by saying that since this is a very rare complication, there is no standardized mode of approaching it. We first look for the adult literature first, and then try a step-by-step approach with ever-intensive modes of care.
Thank you very much, Carlo, and thank you everybody for making this discussion so interesting. And I'm gonna give the floor to Professor Lima again. Thanks.
Thank you.
Thank you, Valerio. And now we stop it, and we reconnected to 2 o'clock with the operative theater of Bologna, that there is a laparoscopic sleeve gastrectomy. Okay, thank you, and I see you later, 2 o'clock. Prova. Professor Bernante, we are connected. Okay.
Okay. Bye again, everybody.
Yes, if you want to
We'll
explain.
start a sleeve gastrectomy in a young female whose BMI is 55, something like that. As you can see, she has a huge fatty liver. We have gained access to the lesser sac, and we go upwards along the greater curvature until we reach the esophagogastric junction.
What is the position and the number of your trocar?
Okay, the patient is with the legs spread apart. She's in a reverse Trendelenburg position. And we are using now 5 trocars, 3 12 millimeters for the camera and for the right and left hand of the first surgeon. and 2 5 millimeters for the assistant for retracting the liver and assisting in the exposure of the gastric field. As you can see, we are here inside the lesser curve. You can see the pancreas down there. And we go up. Vieni un po' più vicino, per favore. Down there you can see the spleen because we are approaching now the short gastric vessels. Così. Ok, bravo, piano piano, bravissimo. Giovanni. Splenic artery here. Andiamo avanti, Giovanni. A vedere qua. We are now approaching the left pillar of the hiatus, of the diaphragm. This is the gastrophrenic ligament, because you have to completely free the fundus. Vieni un po' indietro. Dietro Giovanni. Aspetta. Muoviamo una alla volta. Prendi lo stomaco qua e sollevalo. Qua. Okay. So we need to check all the posterior attachments should be free. Okay. Now we go down. Ora pure lo stomaco là. Giovanni, vieni più lontano. Devi prendermi lo stomaco qua. Mollalo. Okay. Così, basta così. Aspetta che passiamo. We go down until we reach an approximative distance of 5-6 centimeter from the pylorus. Date dietro per cortesia il sondone che è troppo dentro. Mi tirate indietro il sondone, per favore, che è troppo dentro. Un secondo. Sì, sì, retrai, retrai. Vale a posto, adesso controllo. Scaldiamo l'ottica un attimo. Vai, lascia stare, ormai non dobbiamo più. So I can show you, we have the pylorus down there, here. So the distance from the pylorus, vieni qua, seguimi Giovanni. Dietro, Giovanni. From the pylorus to the dissection should be around 6 centimeter. So we free a little bit more. Okay, as you can see here, this is the attachment of the prepyloric region near the duodenum. Usually this ligament, this posterior attachment should be preserved in order to avoid any torsion of the antral region. So this is a landmark for the posterior dissection. And now we have all the stomach free. So now we have to start with the stapler. We are going to use a bougie, a 40 French bougie. However, you have some landmarks that you could clearly appreciate. This is the region of the crow's foot, and you have to stay with your stapler just outside the vessels of the greater curvature. This part of the section is the most important because you can create a stenosis here, so you have to stay away from the end of the vessels. And then we use the bougie to calibrate the bougie is here, as you can see now. We have a kind of bougie that are quite hard, so it's difficult, Giovanni. It's quite difficult to put the bougie inside the pylorus because it is too rigid, and so we need to start, dammi ancora un attimo di quello, the first stapling without the bougie, because otherwise the stomach is going to twist and the section should be. Ok, mi dai adesso la Giovanna corta, per favore. We start with we use the echelon power And we start with the green cartridge. The first one is a green cartridge. No, stai così, va benissimo. And then we go up changing the cartridges. From green, we switch to no, dopo la gialla la seconda. Ah, devi ancora. Okay. From green, we switch to the gold, and then we go up with the blue ones. We usually don't use any buttress material. Chiudilo. In this part, it's important to be more careful in order to avoid any torsion of the gastric tube. Okay, as you can see, we stay away from the angulus, because here is the region where you can create some stenosis. You check on the posterior wall for the same reason. You arrive at the end of the vessels. This is the pancreas. We wait 1 minute before firing the stapler in order to have a better staple line. Mi dite il tempo? Sleeve gastrectomy is a good bariatric operation. However, I have two problems. The first one is that probably is a kind of operation that can create a gastroesophageal reflux in some patients. So you have to maintain a follow-up, endoscopic follow-up to check for reflux. The second one is the complication. Fortunately, with the new stapler, the leak is almost rare, but it's a complication that is difficult to treat. It needs a lot of patience, both from the surgeons and the patient. Okay, now we go with the E la cartuccia, niente. With the second staple, and before firing, we put the bougie inside. We ask the anesthesiologist to help us. So I put the stapler here. Ok, vieni giù. Vieni. Vieni. Aspetta che non so dove sei. Ok, spingi. Aspetta, adesso che ti aiuto. Aspetta. Ok, spingi ancora. Aspetta ancora un attimo. Spingi. Ok, aspetta un secondo ancora. No, ferma, sei scivolo. Aspetta, ok. Vieni. Aspetta che ti aiuto. As you can see, the bougie is quite rigid, so it's difficult to pass the angle, but we manage by. Okay, now we are arrived here, as you can see. Okay, and now we stay. Tienila ferma un attimo, sai, non andare via con la mano. tilde stapler. Fammi vedere il fegato, spostami un po' il fegato che veda lo stomaco. Okay, and as you can see here, you stay near the bougie. But as you can see, the end of the vessels are your marker. Ok, mi guardate un minuto, grazie. Poi andiamo su con l'azzurro. Scusa. Può mollarla, sai, la sono. Poi lasciamo.
Professor Bernante, you have experience of the electrical stapler. And you see.
Yes, this one is electric. This one that I'm using now is electric. There's a battery inside. And now, fa vedere qua la studiatrice. I don't know if you can hear the noise, but now it's working electrically. Okay. And now you have to go up, following this line. When you come near the fundus, you have to pay more attention in order to remove all the fundus, all the posterior part of the fundus, because if you leave that in the next future is going to dilate and the patient could regain some weight. So when we arrive, okay. Ok, mi guardate un minuto ancora.
Okay.
It's important to be very careful to follow a straight line, keeping the same part of anterior posterior wall, the same portion, the same quantity of anterior and posterior wall in order to have a straight tube and don't make any kind of twist. Togli quello zoom che hai tolto, che non ci serve, non abbiamo bisogno di zoom. O dall'altra parte. Ancora uno, perfetto, bravo. Fai un focus qua. Fermo lì, faccio io.
Sì.
Passato. Dammi la Joan lunga intanto che mi preparo un'altra azzurra. As you can see, moving upwards, you have all this part of the fundus, all the posterior part you have to remove completely because this part could be the start of the weight regain, but we are too far now to deal with the posterior part of the fundus. Usually you use 5 cartridges. So you have a staple line of around 30 centimeter. Okay.
Professor Bernante, there is a question from the audience.
Yes.
Does the size of the bougie depend on the age?
No, we use a standard 40 French for every patient. No difference between sex, BMI, or something like that. There are a lot of studies that say that if you use a bougie larger than 40, you don't have a good weight loss. But if you use a bougie of less than 40, you increase the risk of leaks because you do a tube with a lot of pressure for the Laplace law. So it's important. All the surgeons over the world use a 40, 38, 40, no other. Okay, as you can see, okay, siamo alla fine. No, fermo là. Sotto, scusa. No, no, non toccare. Lasciami libero. Fammi vedere qua sotto. Okay, we need to be sure that this posterior part, okay, you can see down there is the pillar, and we are on the left pillar, and all the posterior part of the fundus is removed. And you stay away from the east angle around some 5, 6 millimeters, 1 centimeter. Okay. Now we need the last cartridge to complete the section of the stomach, but it's important that the posterior part should be completely removed. Queste sono fine corso. E vedere la fine della carica, per favore. Ok. Buono. No? Mhm. Ok. Allarga, per favore. Menagement, per favore. Niente. Una forbice, per favore. Se non ce l'hai, dammi l'ensil, che va bene lo stesso. L'ensil, dammi l'ensil. Ok, un'altra Joan. So, as you can see, the fundus is the most part of the stomach that should be removed. It's really large, but it's very important to remove the fundus. And you can see the sleeve is quite linear. Now we retract a little bit the bougie. Tira, tira pure indietro, tira, 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 ancora, 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 ancora. Okay. As you can see, it looks like an hockey club. And now we can do a blue test. Si fa il blu, grazie. And the operation is over. At the end, it's important that the staple line, it's a linear line on the same plane. Sometimes you see staple line that do something like this. And the problem is that when you remove the bougie, the stomach twists on its major axis, so you can have some problem for the patients with vomiting and so on. So it's important to be symmetric, so to choose a line, a straight line. Ok, vai col blu. Okay, the blue is going inside. Okay, as you can see. Okay, passa così. The stomach looks like a symmetric tube, no twisting. And I think that we have finished. Now we remove the tube. We don't use any bag, and we try to remove it from the trocar on my left side, so on the right side of the patient. Okay, if you don't have any questions, I thank you again, Professor Lima, and all the audience for your kind attention and patience. And see you.
Professor Bernante, there is a question from the chat. Do we need to enforce the stapler line with the second stitch?
No, we don't use any second stitch. Sometimes we use buttress materials and the kind of Gore-Tex or something like that. But usually we use it for patients who can have a high hemorrhagic risk, like patients with in therapy, in chronic therapy with aspirin and so on. Otherwise, we don't use any reinforcement.
And the stapler that you use is 3-line, yes? The stapler, yes, is 3-line. Okay.
Yes, 3-line, yes, absolutely, yes. It's really important because the stapler are the most important part of this operation is not the surgeon, but is the stapler. Need to be a very good one. So this one has been designed especially for this kind of operation.
Okay, thank you very much for your very fine demonstration and good work. Okay, bye-bye.
Thank you,
Bye.
thank you, bye, bye.
And now, okay, there is no question and we are finished our meeting today. And the next appointment is in October. And I show you the page of our website. The next appointment is the 23rd of October for the inguinal hernia surgery. The program is that we have 4 surgical procedure in Bologna and 4 surgical procedure in Wrocław. If you want, if you have the cases, it's possible to show other surgical theater. And I say you that 4th of September, there is the General Assembly of our group, and there is the new board, the new president and vice president, and the new board, and we discuss in the General Assembly the topics of the next year. The next appointment is October inguinal hernia, and in December for the 2024 for the pediatric gynecological surgery. And we discuss in the General Assembly the topics of 2025. Thank you very much, Valerio, for very interesting review of literature and the question time. Thank you to the group of Rome for the very interesting topic, and a good holiday. And I see you, because I send to hold my list the General Assembly, and I see in 4th of September and after in October. Bye-bye. Thank you very much.